Moving forward, we're going to now start talking about rhythms that originate within the atria. So we'll call these atrial rhythms. And so these are all going to be dysrhythmias that are caused by abnormal electrical impulses occurring within the atria. So the first one we're going to cover are premature atrial contractions or complexes. Complexes is probably a better term, but everybody says premature atrial contractions because remember, in EKG wise, we're mainly talking about the waveforms and electricity as opposed to the mechanical activity. But regardless, in a PAC, it's a premature atrial contraction. An irritable site within the atria discharges before the next SA node impulse. So basically, you're going to get an early beat, and that early beat originates within the atria. And so, knowing what you know about EKG waveforms, that's actually going to impact the P wave. So, basically, the big thing about a PAC is that it comes early, and the origin is going to be within the atria. So you remember if the impulse is originating at the SA node, you should get this nice, consistent P wave. So in a PAC, since the beat is not originating at the SA node, the P wave is going to look a little bit different. So P wave's different in shape. So as far as criteria, the rate is normal, but for this specific beat, remember it's going to come early. And so we're talking generally about one beat here. It could be a few of these in a row, but oftentimes it's just going to be one. So the P waves are premature and they also differ in shape. Those are the big thing. Everything else is pretty consistent. So causes could just be stress, caffeine, electrolyte imbalances, or it could be disease. Very common in healthy adults. As long as they're not too frequent, it's not thought to be a negative thing. So patterns of PACs, basically if you get one, it's just called a PAC. If you get two in a row, it's called a couplet. Three in a row, triplet. And you probably want to use the terms atrial couplet, atrial triplet, because we are going to see a similar thing with some of these ventricular beats. So, and then if every other beat is a PAC, we would call it atrial bigeminy. If every third beat is a PAC, atrial trigeminy, and then quadrigeminy for every fourth. So here we go. So you're seeing a couple of places here in this strip where you actually have an early beat. So I'm going to focus on this one just because you can see we have, if you start right here, you have a regular QRS complex, P wave QRST, P wave QRST, P wave QRST, and then all of a sudden this beat comes early. Now in this case, you don't actually see a P wave, which could also just tell us it's a different shape, maybe biphasic, so we're not seeing it. But the big thing is it's early. Notice also that the QRS is not really affected. It's still got the same shape. It's still really narrow, so the QRS is still within its normal range, and the T wave is also. So really the only thing that's going on here is the P wave is either different shape or you can't see it, and then also the beat is coming early. There's another one right here, same thing. Comes early, P wave is different shape or you can't see it. All right, so treatment, if necessary, it just depends on what's causing it. If it's electrolyte abnormalities, that would need to be treated. All right, so moving on. Atrial flutter. So atrial flutter is going to be consistent or really similar to something called atrial fibrillation, but there is a key difference that I want to talk about. So in atrial flutter, there's a site within the atria becomes irritable and starts depolarizing the heart at a regular basis that's really, really fast. So the AV node is going to prevent the ventricles from keeping up with the atria. So basically what you're going to see is a really high atrial rate and a somewhat normal ventricular rate. And thus you're going to have more P waves compared to the QRS complexes, and we're actually going to call the P waves flutter waves in this case. So conduction ratios of the atria to the ventricles could be 2 to 1, 4 to 1, 6 to 1. And as far as the rate, the atrial rate's going to be really high. Ventricular rate's going to vary, but it could be somewhat normal. As far as the P waves go, you're going to see these kind of odd-shaped P waves, and we're actually going to call them flutter waves. And PR interval is not really going to be something that you would measure here, and you'll see why when you see this. And then QRS is going to look somewhat normal, nice and narrow like it should be. Causes ischemia, disease, but this is not something that would be considered normal. So looking at an EKG strip, this is atrial flutter. So you're seeing about 3, in this case, 3 to 4 P waves or flutter waves per QRS complex. Now, the number one thing that you should remember about atrial flutter is that it kind of gives a sawtooth appearance here. So if you think of like a serrated knife or a saw, it kind of gives that sawtooth appearance. And then you get these nice regular QRS complexes. So one way to distinguish this between the next one we're going to talk about, which is called atrial fibrillation, is look how regular the QRS complexes are. They're very predictable. You're not going to see that in atrial fibrillation. All right, so atrial fibrillation, similar, but it's going to be a little bit different. So the atria are depolarizing even a little bit faster. So they don't even have discernible P waves or flutter waves. It's gonna look like just a jagged line where the atria are shaking or fibrillating. So the EKG criteria, very high atrial rate, ventricular rate's gonna vary. Another big thing, the ventricular rate is gonna be irregular, and you'll see that. So as far as the P waves, you don't really see them. The little jagged line are just gonna be called fibrillatory waves. Not going to be able to measure PR. QRS is going to look somewhat normal, believe it or not. So cause is very similar to what we saw for atrial flutter. And if you look here, you can see it. So you just kind of see a jagged line with these QRSs interspersed. Now compare this with what we saw for atrial flutter. Look how irregular these QRS complexes are. We can't really predict where the next one's going to come. So that's one easy way to discern between atrial fibrillation and atrial flutter. Atrial flutter, the QRSs are very regular. Atrial fibrillation, they're not. All right, wandering atrial pacemaker, a little bit different here. So the origin is going to be within the atria, and to be diagnosed with wandering atrial pacemaker, there needs to be at least 3 different P wave configurations. So that's going to tell us that there's at least 3 different sites within the atria where the origin of the beat is coming from. And so that's why they call it wandering. It's like the atrial pacemaker is wandering around the atria. And so rate is going to be somewhat normal. Rhythm could be either regular or irregular. P wave sizes, it's just going to change. And you need at least 3 to meet the criteria for wandering atrial pacemaker. QRS, again, is going to look somewhat normal. So causes mainly just cardiac disease. All right, so wandering atrial pacemaker, if we look at this, you're going to see, first of all, you notice QRSs that look somewhat normal. It doesn't appear to be regular here, but let's look at the P waves. So P wave here, that looks like a somewhat normal P wave. Here, its shape is a little bit different, and the PR interval definitely changed. And if we look here, there's really no P wave whatsoever. It looks like the P wave's kind of mixing in with the QRS. There's another one here that looks different. And then this one looks like this one. This one looks like this one. So in this specific strip, it looks like you're getting about 4 different P wave configurations. And so that does meet the criteria for wandering atrial pacemaker. So again, what's going on physiologically is that there's at least 3 different sites within the atria that are serving as the pacemaker, and it's kind of alternating between those sites. All right, something really similar that is just has a different name due to the rate. multifocal atrial tachycardia is basically if you have wandering atrial pacemaker, but the rate is elevated. So if the rate is over 100, we now call it multifocal atrial tachycardia. So everything we just said is true, but the thing that differentiates the wandering atrial pacemaker from the multifocal atrial tachycardia is just the rate. That's it. So causes similar heart disease. In this case, multifocal atrial tachycardia is more so caused by pulmonary disease as opposed to just strictly cardiovascular disease. And that's why I underline this. All right, so here it's a little bit hard to see because the rate's so high, but if you kind of look where the P wave would be, like you're seeing an upside down or retrograde P wave right here. You see one here that doesn't look like much. You're seeing something here. It looks like the P wave's joining with the T wave. Same thing here, but different shape. Another one kind of looking strange here. So you're getting at least 3 different configurations of the P waves at a very high rate. So that meets the criteria for multifocal atrial tachycardia. Or a congenital effect that I wanted to talk about that has to do with the atria. It's called Wolff-Parkinson-White Syndrome, WPW. It is under the umbrella of what's called a pre-excitation syndrome. So basically, there's going to be an accessory pathway that exists that's not normal. In this case, it's called the bundle of Kent. So there's an accessory pathway between the atria and ventricles. So remember, in a healthy heart, what should happen is the AV node, right around the AV node and the AV junction, you should get a slowing of the electricity flowing from the atria to the ventricles, and that allows the atria to contract before the ventricles. Well, this accessory pathway called the bundle of Kent actually is a separate pathway that is basically a separate highway for the electricity to get from the atria to the ventricles. So what happens is the P wave, or the ventricles are going to contract earlier than they should. So thus you're going to get a really, really short PR interval, and because this normal delay at the AV node is bypassed. So this bundle of Kent that I was talking about, it is in everyone's heart, but generally it goes away by birth. So, but in some people it remains, and that's when it potentially could be a problem. And the other thing that's noticeable in Wolff-Parkinson's-White is that the QRS is generally long. So what happens is part of the ventricles are activated via this bundle of Kent. And so you get this kind of early activation of the ventricles before the rest of the electricity gets there via the normal pathway. And so you get kind of this, they call it a slurring of the QRS, where it kind of starts to go up before it really takes off. And I'll show you a picture of that. So this is thought to be that accessory connection right here. And so you get this kind of early stimulation of the ventricles via this pathway, and so you get this early kind of contraction and depolarization of the ventricles before the normal pathway gets there. And so what that looks like on the EKG is you get this kind of beginning of the QRS before it really takes off. So normally you should have this nice narrow QRS, but in this case you're going to get this kind of really wide beginning to the QRS before it really takes off and goes up. And that beginning right there is called the delta wave. So delta wave is what you would call that early depolarization of the in WPW. So some quick background on it. More common in males. So though 2/3 of the people with WPW don't have any negative effects as far as heart disease. It is treatable. Usually they go in and do an ablation technique if they think it's going to be a problem. But the biggest problem would be it does predispose someone to dysrhythmias, because you lose that kind of protective protection of the AV node, slowing down the impulse going to the ventricles. And here's another picture of that delta wave I was talking about. So everything looks normal. You just get this widened QRS. In the beginning of it, you get that slurring. So this is the delta wave, and that's the WPW. If you look at a 12 lead with it, It's not discernible in all of these leads, but there's definitely a few, like here, V1, V2, V3, you're seeing that delta wave here, also V4, V5, V6. Maybe a little bit. Also in, well, not really, I don't really see it too much in lead 2. So it's mainly in the precordial leads in this 12 lead that you can actually see the delta wave. All right, a couple more. We have PAT, and then we're going to talk about supraventricular tachycardia, which is actually really, really similar. So paroxysmal atrial tachycardia. Basically, if you get 3 or more of those PACs that we talked about that occur in a row, it's now called atrial tachycardia. So it's really, really fast, and the origin is going to be the atria. The term paroxysmal means sudden onset and stopping. So this rhythm could just all of a sudden come on. If you have a normal sinus rhythm, you could have 10 seconds of PAT, and then it'll go back to normal sinus rhythm. So that's where the paroxysmal comes in. So a series of rapid beats generated from the atria. The ventricles usually go along with it, so you're going to have 1 P wave for every QRS. So EKG criteria, 100 to 200 beats per minute. The rhythm is going to be regular. P wave, the shape is going to be a little bit different because the origin is not the S8 node, and the rate is generally so fast that usually the P wave and T wave kind of merge into each other, so it's hard to distinguish them from each other. And the PR interval is going to be really hard to measure because the rate's generally so high. So causes, medications, or like we said, sometimes WPW, that pre-excitation syndrome could lead to this. So this is it. So this would be PAT, where you don't really see any discernible P waves. They're, in my opinion, they're probably hidden in this T wave right here. So very fast rate, and then all of a sudden it just goes back to normal. So sudden onset, sudden stopping. So one other thing that a question always comes up, which is actually a really good question. If you see this, how do you know it's just not sinus tachycardia, like a really, really high heart rate of 180 to 200 beats per minute? You have to consider the overall picture. If this is occurring at rest, it's probably not sinus tachycardia. If this is occurring during like high intensity exercise, more than likely it's simply sinus tachycardia. So that you have to also kind of take into account the situation. But this PAT will generally just come on at rest. Like all of a sudden, normal sinus rhythm, and then something could cause the heart just to go into this few seconds of really, really high rates where the beats are originating at the atria. All right. And the other one that is really similar, paroxysmal supraventricular tachycardia. If it's not sudden onset, we would just call it supraventricular tachycardia, but just think quickly about what that means. So we're talking about high heart rate where the origin is above the ventricle. So basically, this is kind of talking about atrial tachycardia, but the big thing that is going to make this different, what we're going to distinguish it, is the origin. So there's different forms. The part we're going to talk about here, and I'm going to use these terms interchangeably, so PSVT and AV node reentrant tachycardia. I'm going to assume for the purposes of this class that the reentrant tachycardia is causing this. So I want to talk about what that is. This is a rather complex phenomenon. So what you're going to get here is re-entry of electrical impulses within the AV node. And what that means is, just to give a little background, if this is the AV node, here's the atria up here, here's your ventricles here. There's 2 pathways that electricity could go. It could go down what's called the fast pathway or the slow pathway. The normal route is going to be the fast pathway. So when electricity is flowing from the AV node down to the bundle of His, it's going to normally go down this fast pathway. So that's great, but the fast pathway does have a longer refractory period. So after electricity flows through here, it takes a little while before it can actually accept a new electrical impulse coming through here. So what could potentially happen is if you get a premature beat while that fast pathway is still in its refractory period, the impulse has no other choice than to go down the slow pathway. And so let's assume that all of a sudden everything's normal and then you get a premature beat coming from the atria. And so the fast pathway is still blocked because it's in refractory period. So that impulse has to go down the slow pathway. All right, not a bad thing, right? However, here's where the trouble begins. By the time that impulse gets here, going down the slow pathway, the fast pathway is ready to go again. So it's out of its refractory period. So you can actually get a retrograde impulse going through the fast pathway. And then you end up with this circular set of impulses going through the AV node. And that's why it's called re-entry, because it's kind of, the impulse is re-entering the AV node. And so what you get is this loop like this. So you get electricity just circling around the AV node. And what's the problem with this is it's really fast, and so you're stimulating the atria to contract and the ventricles to contract almost at the same time. And so you're going to have a really high atrial rate, really high ventricular rate, and the atria are actually being depolarized in the opposite direction. So normally we get the atrial depolarization coming back this way towards the ventricles, but in this case, due to this re-entry, they're actually being depolarized in the opposite direction. So you could guess what that's going to make the P wave look like. So the P wave is going to be upside down, because normally we get an upright P wave because electricity is flowing kind of down and across the atria, and in this case, the electricity would be flowing up, back towards the SA node. So you get electrical impulses going in a circular fashion and simultaneously stimulating the atria and ventricles. And so since they're stimulated almost simultaneously, the P wave may be before, inside, or after the QRS complex. And if you can see the P wave, it'll be upside down, like we were talking about. But when you look at this, you can't really tell the difference between what we saw for PAT, and I would never ask you to distinguish between PAT and PSVT because they're too similar. So think of the difference between the two as kind of being the origin. So here's another picture of it. So really, really high rates, and don't really see any discernible P waves here. So really, really high rates, and higher than what you would get during normal sinus tachycardia.